building on clinical strengths to mitigate harmful social determinants of health for maternal health. As you saw, we are recording today, so we wanted you to be aware of that. And next slide. So this is again being supported by the Maternal Health Learning and Innovation Center, and we are a national resource center to accelerate evidence-informed interventions to advance equitable maternal health outcomes. This slide shows logos for our wonderful partners, and I see a few of them on today. We also want to thank our funders, the Health Resources and Services Administration, the Maternal and Child Health branch, and just want to be clear that we're grateful for their support, but the words that are spoken today are those that we own ourselves. Next slide, please. So I'm really excited to introduce our speakers today. We had an awesome first session. And if you missed that, no worries, we recorded that and we will be sharing that with everyone after we finish today's event. But really excited to have them back. So Dr. Simone Chinnis is an instructor in the College of Nursing at the Medical University of South Carolina. She is a bilingual nurse practitioner and leads research funded by the Duke Endowment to strengthen nursing training and practice. She's also Director of Community Engagement at MUSC Nursing and serves as the inaugural director of a nurse practitioner telepsychiatry program. Dr. Kristin Tully is a medical anthropologist and research assistant professor in the Department of Obstetrics and Gynecology at the University of North Carolina at Chapel Hill. Currently, she serves as a core team member of the UNC Health Executive Equity and Inclusion Council. She is principal investigator of an AHRQ-funded patient safety learning lab, and she's an investigator on the American Heart Association-funded Health Equity Research Network, where she serves on structural social determinants of health core. So you really are in a treat with these awesome folks today. Next slide. And just a little bit of housekeeping. As I mentioned, the recording and slides will be available, although we decided if this is a place where we just have lots of conversation and chat, that we're going to make some decision about making the second recording available to everyone or just sharing it with you. But as the slides will be available, and we will email all of you follow-up, including an evaluation, which will come in your inbox. You all are going to need to make sure to mute yourselves and decide how you want to be on or off camera. Please ask questions and share your thoughts using the Zoom chat. We will be keeping an eye on that. And today we are going to be using Mentimeter for ways to also help you engage. So today we hope for engagement. And so those are some of the opportunities that you'll have. Last thing is, if you would like to ask a question or make a point, there will be times for you to do that over the next hour. Please raise your hand with that Zoom function so we know to call on you. So I think with all of that housekeeping done, again, welcome everyone, and I am going to turn it over to our speakers.
Thank you so much, Dr. Verbees. It's really excited to be here together again and to go deeper. So thank you for joining, and I'm so grateful for Dr. Chinnis for a partnership for this conversation. And so we want to think together around what's working well clinically to build relationship with folks that we're seeking to serve, and then address challenges with them. And so we are going to do a very brief recap from last time, since that's recorded, and the slides will be made available as well. I just wanted to make sure to offer clear definition around what we mean by social determinants of health. And it's defined by the World Health Organization as all the things, the conditions in which people are born, grow, work, live, and age. And I talked last time about loving and thriving together, that's what our goal is. And a really important piece of this definition and the reality is that this is about power. The World Health Organization definition in the same sentence includes the SDoH is about the wider set of forces and systems shaping the conditions of daily life. And so, again, a lot of what we talk about is on the system and interpersonal levels. We briefly talked last time about policy, and Dr. Chinnis will talk about sort of that full stream and steam effort approach shortly. So again, we want to acknowledge what we're talking about is extraordinarily multifaceted, and then we need effort on all the things, but not from every person all the time. And the impact of this is enormous. So addressing, access to food, transportation, safety, support networks, and other contexts can change people's stories, their narratives and their outcomes across generations. So, for birthing people and their infants and their families, including the extended family and the grandparents, and then generations to come. So nothing more worthy that I can think of is spending time and being in community around. And so this is the highlights that I just wanted to elevate from last time. We sort of walked through this, and it's also detailed in this open access article, which is cited in full at the end of these slides, and we can also share the PDF if that's useful. But key strategies from what we have heard from pregnant and postpartum people and also healthcare team members is that this is a everybody, everyday thing. So information, resources should be offered to everyone. And the ways to do that vary, and people, want organized information and through multiple modalities. So a key part of what we do at UNC and in partnership is making things open access. And I think that's really key. And then we recommend, transparency, not only with what's available, but, how we engage with this. So if you are offering screening opportunities, to make sure that there's framing. And by that, I mean a brief introduction in writing and also verbally when we're inviting people to share. And transparency with data governance. People are worried about what is in their record, and rightfully so. And so if it is stored, that should be communicated. And if it's not, then that's also useful information. And there are trade-offs with, access to data. And then, a key part, and I think what we'll go into more today, is around building relationship. And that takes time, and there are strategies to do that well. And that includes, normalizing challenges and service utilization. And also, we're not talking about toxic positivity either. This is about being aware and real about what's available. And sometimes there are system constraints, such as extensive waiting times. And so that should be part of the conversation too. And the last thing I'll share here is just to reiterate, the extent to which we can leverage the point of care, I think is something to reflect on. We are responsible for doing all that we can when we can, including as soon as we can immediately, and not having the ideal be referring out. And of course, that's needed for depth and long term, but we want it as soon as possible. And we have a slide coming up around trauma-informed care. which I think is helpful. Okay. And so please put in the chat, if there are reflections or if you want to engage around that list of recommendations for best practices. And so what we wanted to do now is to start the engagement. There are, quite a few people on the call, and we do have the opportunity for you to raise your hand and come off mute. We were thinking that engaging through Mentimeter would be a good way to start the active communication in this session. So I'm going to stop sharing my PowerPoint and go to menti.com. And so we're going to put in the chat the link to this website and this code, which you can also use your phone to scan the QR code and then see some of the responses. And we have this a few times in this session, and we'll see how it goes together. So I'm going to stop sharing for a moment. Screen. Oh, good. There's responses already. Yay. Let me share. Okay. And okay. So, and we won't spend long on this. I just wanted you to see how Menti works and to offer some responses. And so this first question, does your clinic screen for social needs in maternity care? And this is interesting. I have these options, yes for everyone, yes for some,
Hi, Maria.
or
Hey,
no,
Dawn, how are you?
or not routine.
I'm good. How are you?
I'm good.
And so in a moment, I'll go to the next slide, just so you can share responses around that component. And with these responses, I will integrate the results into the PowerPoint that we distribute after this session. And so thank you for contributing to that. And then this next question, which builds off the first one, and it's the same QR code and everything. Does your clinic provide resources for SDoH in maternity care? And I've learned using Menti and disaggregating results from Dr. Karen Scott recently did a training that I had the opportunity to be in. And so I thank her for this. And so this is interesting because, the resources that we have. So yes, we have resources for some things. That's what most people are saying. And then, so some people who have resources are not screening. And so some who have resources then are screening everyone, and some screening part of the population. And yeah, I put this in right before the session because the unsure, I think, is probably pretty common.
And Kristin, just there's a note in the chat that if people aren't in a clinic, they kind of just need to observe this part because like they're not able to answer.
Yeah.
Yes.
Thank you. And it's the same I would offer for research, that if we are assessing people's social needs, then are we providing resources for them at the end of their participation? So that is another thing to consider. Okay, so I'm going to share the PowerPoint again and shift it to Dr. Chinnis.
And so the figure in front of you is a pictorial depiction of the social determinants of health and health-related social needs. The diagram manifests 3 segments which relate to different points when a need needs to be addressed, where issues arise and you have opportunities to intervene. The river is a depiction of the type of actions that need to occur. The bank conveys the objectives and how one would address those situations. As one moves upstream, the impact one has starts on the individual level, progressing to the coordination of care across sectors to promote health equity and achieve holistic care, and then ascends to impacting the community as a whole. The most basic form of intervention is to address an individual's healthcare needs. This level of support in the provision of services can then be enhanced by not only addressing the individual's healthcare needs, but also addressing the individual's social needs. This form of care transcends the realm of health services, entering into the realm of community services, community resources, connectedness, while overall eliciting a higher form of wellness for individuals. This is where we can start. But in order to elicit structural changes, we will need to improve the conditions of various communities, enhance the infrastructure of broadband in numerous areas, as well as the sharing of information, and address structural racism, create policies to ensure that equitable care is provided to all social groups. We need to have a multi-sector level of involvement through private and public sectors. We need to ensure that policies drive this level of change, and through bi-directional movement, health outcomes will improve and health disparities will no longer be perpetuated. So this pictorial depiction is a roadmap of how each of us can do our part as we try to elicit change and address social determinants of health. Next slide. And so in front of you conveys impact. Most people state, so social determinants of health, they're non-medical things that one can address in an attempt to improve health outcomes. Does this actually work? The Department of Health and Human Services released information in 2022 manifesting the impact of addressing various social determinants of health. When housing insecurity is addressed through the provision of safe and stable housing, inpatient stays, emergency department visits, the use of long-term care, utilization, and in some cases, people experience an improvement in health outcomes and or reduction in overall healthcare cost. When food insecurity was addressed, for example, through the Older Americans Act, which we will now refer to as OAA, this act funds meals, job training, and provides senior centers for the elderly. The provision of nutrition services was associated with a reduced in healthcare utilization and improvement in healthcare outcomes for older adults. A study of the OAA manifested that older adults who received home-delivered meals had greater improvements in anxiety and viewed themselves as healthier when compared to counterparts who were still on a waiting list for services. When non-emergent transportation was provided, it manifested a cost-effective use of preventative care, which is a cheaper form of care when compared to emergency services. There are other interventions that one can employ, such as social and economic mobility through the form of stipends and provision of additional resources, financial resources monthly. In Gary, Indiana, it was found that supplemental income provided to mothers who was associated with a lower birth weight in these families, as well as it led to an increase in preventative services. This is important when you're thinking about healthcare costs and how we can impact the system. Next slide.
And go ahead.
No, it's fine. So in reference to the objectives, our goal today is to identify examples of institutional and practice strengths for mitigating harmful social determinants of health for maternal health. This session is a collaborative think tank to permit an exchange of ideas about approaches and resources used to address social determinants of health and maternal health as part of building on clinical strengths. Kristin.
Thank you. And so as we continue to go through, we'll invite you to offer thoughts around the feasibility and impact, and continue consideration together around plans for implementation and sustainability around these core, goals of being more universal, strength-based, and timely.
And so as we start talking about ways to impact the system, ways to provide resources to our patients, ways to serve as an ally in situations when we know that people are adversely impacted, we must consider that this is not a local problem. It's not a county problem, it's not a state problem, but it's a national problem that we must address. And so one of the main things we're going to do today is just provide you with various resources you can use on a day-to-day basis. So these resources can be used in a clinical setting. They can also be used in a research setting. So one of those resources is provided by the American Academy of Family Physicians in the form of a neighborhood navigator. So this is a digital tool that Kristin will display shortly, where you can enter in your zip code. It doesn't matter wherever it is that you reside, and resources for that area will populate. Resources in the form of medicinal needs, housing needs, financial needs, food insecurity, resources to address a plethora of social determinants of health. We're going to play a brief snippet of a video which basically provides quick training on how you would use the service.
Hello, I want to take this opportunity to welcome you and share some key information to help get you started. As a helping professional, you know how difficult it can be to find and connect to services. You may work with a variety of clients with very different needs, which could range from needing assistance finding a food pantry, housing, mental health resources, or transportation, just to name a few. Fortunately, there are tons of great nonprofits, public services, and even some private services that exist at a free or reduced cost. But oftentimes, it's incredibly difficult to find information about the services that are available in their area, let alone connect with those services. Through this platform, we can build a bridge to help people in need find and connect with the services in their community that can help. This platform is designed to help you find social service resources to support the health and well-being of the people that you're serving. Specifically, you will find direct services such as food pantries, housing assistance, transportation programs, nutrition education classes, and much more. Together, we can address social issues and support the lives of people living in our communities, empowering our community members to take advantage of programs that can improve their overall health, wellness, and happiness.
Hello. I'm going to walk you through how to use another one of our great features, referrals. Anyone can make a referral, whether it's for yourself or on behalf of someone else, simply by using our Connect button.
And Dr. Chinnis, would you like this to continue? Or?
Oh, no, that's fine. And so the purpose of that demonstration is just to show you how easy you can employ services within your specific area. As we have these sessions, we want to ensure that you're provided with resources that you can use on a day-to-day basis, be it whether if you're in an acute setting in the hospital, or even if you're in an outpatient setting, or even if you're working in research. The addressing of social determinants of health is not a me thing or a you thing, it's an us situation. It's our job to connect people to resources, and not just by a referral, but through a direct, warm handoff, contacting entities, helping them to bridge that gap of connectedness.
Thank you. And I'm going to share my screen again to invite you all to contribute to Mentimeter. So we have, well, I have some questions around relationship now, because before we offer more specific resources and read the chat for you to offer things that have been helpful in your practice or in research, I wanted to make some space for a relationship, right? Because if we don't have that connection with people and therefore they aren't honest or comprehensive, then there's not the ability to make a bridge to somewhere. So I'll share my screen and invite you, please, if you'd like to contribute components of positive clinical relationships with patient and families in maternity care. And This is beautiful. We can all see what's coming through with trust at the heart of this already. And trust is earned.
A key thing that I see there is seeing one another's humanity. This is imperative when you're building bridges of connection between people.
And I see the empathy and compassion. We have follow through, keeping your word. We have these, thank you, what I would also consider to be core aspects of connecting with people, of care, and of the practice of love. So thank you. I will share that slide with you all. And I'm going to move to one more at this time. And so I wanted to share this multiple choice. Do you think that's what people experience? Do patient and families experience those components of relationships and maternity care? There you go. Sometimes. Thank you. Yeah. And probably disproportionately so, depending on a lot of factors. And I just, before we move on, I want to elevate structural factors and staffing levels. Okay. This is not just about will, this is about capacity and support for the healthcare team. Okay, thank you. I'm going to stop sharing to go back to the slides. And so I wanted to share this is a screen grab from a video of interaction in the inpatient setting, which again is part of the continuum of care. And we focus a lot, of course, around building relationship prenatally. And then continuing that, labor and delivery, the immediate postpartum, the transition home, and then for postpartum care to be an ongoing resource. And this is part of the ARC funded Patient Safety Learning Lab, where we partnered with healthcare team members and families with their full awareness to document their journeys through care with IRB approval. And I won't go into the methods here. I just wanted to share this example and invite you to consider how this interaction is structured with the mom laying in bed with her baby and with two healthcare team members standing next to her and at the foot of the bed, and her companion nearer to her. And this is a Spanish-speaking family, and one of the healthcare team members is an interpreter. And so, you know, when we think about connection and comprehension and power and the ability to ask clarifying questions and to hear as well, there are lots of things to consider. And because we're asking people to be vulnerable, to share their hardest parts of their life so that we can help, you know, for them and their baby and their futures. So when we do that, you know, it's easy to think about the individuals and how we might equip them to advocate for themselves. And while there's a place for that, expecting people, right, to navigate as a function of their privilege, as discussed last time, is inappropriate, and self-advocacy doesn't make sense when you have only slept for a couple hours and when, you know, the information might be used against you and when you don't know what the purpose is and what benefit might come of it. And Mom shared with me in an interview, you know, that hard parts of her story along with joy. But then she said, you might be wondering why I didn't advocate for myself, you know, sort of why I let this happen. And I was not wondering that, but she went on to share this analogy. She said, you know, it's like whenever you're caught in an ocean, and if you've ever been caught in a rip current, and then you get a wave and you get a wave, and that's how people drown. And so we have shared this in a publication, and I've talked about this with the media. And I think that this signposting that it's, you know, a million grains of sand that add up. Sometimes we have very acute events that happen, but usually, I mean, this is what relationship is over and over and over. We have such an immense opportunity to connect and to first, you know, do no harm. And I wanted to show you from our filming research what the waves can look like. Again, this is in the inpatient setting, and I won't spend a lot of time on this today, but it's just every few minutes, over and over and over and over again. We have interactions that are not optimized. And so in this case, postpartum family is striving to be supported around lactation, but the mom is hungry. She says, I just really want to eat. And so she is not ready to feed and have an observation and assessment, which of course is important for discharge readiness. But then a few minutes later, she's concerned that she's just now finding out about this with regards to pain options for managing her recovery. And then she should only have to say it once and interrupting. And then the language that we use to convey, you know, the purpose of encounters or of, you know, aspects of care, those matter. We talked briefly last time about words that work. And in this case, the words were the lactation team needed to witness the scene, meaning observe a feed. And so then at 10:19 a.m., there's a nurse holding the baby and listening to the parents, and the mom is saying, I'm sorry, I just don't feel heard. And then they're saying, we've had a really rough day. And it's 10:19 in the morning. And so then if someone walks in with a screening form, you know, this is the context that we are sometimes in. So it's important to situate, you know, social determinants of health, social needs in the context of quality care. And I have one more example, an area for strengthening. And so this is another Spanish-speaking family. The postpartum patient is in the bed and she's expressing milk. And a healthcare team member comes in and speaks English to this Spanish family. And the clinician is asking, do you want to go home? Are you ready? And like talking about discharge preparation. Again, not in the language that they can understand. And then the clinician says, anyway, let me check your breast. And then she does. And so, you know, consent and connection and the compassion and the empathy and what are the things that you all said, the active listening, that is not universal. This is intimacy without trust. And so there are a lot of things that we can do and that many people are doing very well and that we need to celebrate and grow. And so this recent publication by Dr. Amina White and colleagues outlines, things that people experience that might be traumatic or stressors. And that's, the first bulleted list. And then in this article, they talk about universal precautions, like we can be trained and practice and, have simulation and be accountable for, in a positive sense, approaching people in appropriate ways. And so, verbally and non-verbally, and that's what I was hoping to share in these examples, whether it's not just, eye contact, and sometimes backs are turned to the computer, and that's a contributor, the amount of clicks that are currently required. And so there are a lot of things that work, and I invite you to share, in the comments, or we can come off mute shortly around this. So this is much, much more than asking questions and doing it in a sensitive way. It's around how we care for folks. And I wanted to share that we have created animations from the observational research because you're listening to me, talk through these scenarios and share quotes. And so we have done this for multiple families, so that we have these short, they're like 2-minute interactions, so that we can then be more aware and reflect on what was happening here and how might the system of care be improved. And so these are open access on our website that's listed here. There's a few online, and we have a bunch more coming soon. And in this one, the family's getting ready for discharge again, and then the nurse is asking around medication, and the mom says, and you'll see the animation, which will be much more effective than me talking through, but the mom says, can I just take his? And he has the same prescription. And he goes, yeah, because to be honest, I don't take mine. And the nurse says, oh no, they'll probably tell you, to get your own so that he can have his, but then what you do is up to you. And so what doesn't happen is sort of a pause and, hearing perhaps what's being shared, which could be barriers to getting the medication, which could be transportation. This family was picked up from the hospital. It could be financial. There could be a lot of reasons, and we don't often have enough time and, again, emotional bandwidth to be able to hear what is being shared, and therefore, go beyond the tip of the iceberg and be of service meaningfully. And so we have examples of more resources coming up next. What I wanted to share before we get into more of these specifics is Dr. Monica McLemore's framework for moving, continually toward more health equity. And she outlines these multiple levels of retrofit, reform, and reimagine, which are all incredibly important and necessary, and we can do, in parallel as a community. And so retrofit is around tailoring care. So given the current reality, given the constraints and the social structures and the healthcare systems, how might we intervene now to support birthing people as they get pregnant, and they're pregnant, become parents. Reform is around system strengthening for more holistic care. So how might we implement improved clinical systems of care for people to achieve more equitable person-focused care for safety and wellness? And reimagine, right? We can make this all different. How might we go upstream, just like in the illustration that Dr. Chinnis shared, and address the structural drivers, such as the hierarchy of human value that perpetuates these inequities. So each of those are different scopes, and they're all incredibly important.
And so as we continue to encourage you to become proactive, to manifest care and concern and carinho to your patients, to your participants, we have to also share with you resources that you can use. The first resource that we showed you was the Neighborhood Navigator. Another resource we're showing you now is 211. This is a national number that can be dialed. This number will provide you access to services for utilities, for transportation, behavioral health services, depending on whatever part of the country that you reside in. It also provides access to medical services at reduced cost. It's understanding where can you turn no matter where you are to meet the needs of patients. Because it's not enough just to screen for social determinants of health. We have to also act upon it. We also have to connect people to services, and we also have to develop that relationship where they know they can trust us, not only to obtain their information, but to do something with it. Next slide, please. And so additional services, Medicaid provides a plethora of programs and services to its recipients. Numerous people qualify for Medicaid. One of the things is you have to qualify. So anyone who is 65 years of older, or if you have a disability, or if you're pregnant, part of a low-income family, you qualify for Medicaid. And in reference to services that are for the maternal population, there is the Be Smart Family Planning Program. There's maternal support services, the Baby Love Program, and there's also pregnancy medical homes. The caveat is we have to inform people through health education that these services exist. We have to encourage them to contact their individual, their caseworker at Medicaid, in an attempt to ensure that they are privy to these services. Next slide. Another service is WIC. So the Special Supplemental Nutrition Program for Women, Infants, and Children is actually sponsored by a federal grant to provide low-income pregnant, breastfeeding, and non-breastfeeding postpartum women, infant, and children up to 5 years of age who are found to be at nutritional risk. It's there to address food insecurity. It's there to provide nutritional supplementation. But this is also a service that someone has to be referred to or connected to in order to be used. Next slide. And so in front of you, there's a slide manifesting, once again, a national resource for maternal behavioral health services. Behavioral health conditions do not discriminate by race, ethnicity, gender, religious beliefs, whether or not one is pregnant. Chronic behavioral health conditions, they don't stop during pregnancy. In fact, they may even begin during pregnancy. Anytime you are in some place where you meet someone who may have a behavioral health condition, please take note of that condition, screen for that condition, and connect those individuals to resources. In front of you, this is a national resource you can use. This resource provides behavioral health support before, during, and after pregnancy. Next slide. And also, in reference to diapers, infants need diapers. 1 in 3 children in the United States are born to a family that's not in a financial position to purchase adequate diapers. In absence of adequate diaper changes, children are at risk for acute conditions like urinary tract infections, yeast infections, diaper rashes, and a slew of other acute conditions. However, in every community, a diaper bank exists, and those diaper banks are supported by the National Diaper Bank Network. Our job is to connect with local diaper banks in an attempt to ensure that we are addressing diaper insecurity. Next slide.
Thank you. And I just want to elevate with the National Diaper Bank Network. They also address period and menstrual supplies. We're working right now around menstrual equity. And so as we think about, postpartum hemorrhage, for example, being key warning sign and leading contributor for maternal complications and mortality, a lot of people do not have access to pads. And so including on the unit, on the postnatal unit. So stocking enough supplies in the room is a retrofit. So we can do that easily. And then we can be forthcoming with programs that provide access to menstrual hygiene products, because there's an incredible need. And as this publication around infant diapers show, it affects everything, people's lives. A lot of folks are needing to make very fundamental trade-offs with what they prioritize.
Dr. Tully, would you like to address New Mom Health and Salud Madre?
Yes, thank you. And so these are more open access, non-commercial sites that we, as a UNC team in partnership with community-based organizations and families and healthcare team members have developed and continue to strengthen. And so in English and in Spanish, it's focused on postpartum information centered around the birthing parent. And so there's a lot of information that has been written in a tone and with positive images in collaboration with folks. And there's a directory. So I wanted to signpost that as well, because there is quite a lot and we continue to grow that. And one aspect of newmomhealth.com and saludmadre.com is that we have tools for use in clinical practice. And again, these are free. Please download them. And if you're in North Carolina, they're also available through the Department of Health and Human Services for printing. And an example here is a birthing parent health information document that outlines not only warning signs and when to call 911, but also things that are concerning when you should call your healthcare provider. And again, highlights of taking care of you, like what is normal or much more common and not clinically concerning, but may be very much affecting your daily life. So we have many examples, including a postpartum visit checklist that asks what's going well. And so in these next few minutes, and we'll stop soon so that we can listen, I just wanted to share, as mentioned in the last session, this postpartum discharge change package. I referenced that, and I wanted you to see that it's full of resources. So for all the things that are recommended as best practice, and I just pulled out one here, like connecting postpartum patients with virtual support, such as peer connection groups and texting programs. Then for all of the things, there are links to examples of what is accessible on a national level. And so here, for virtual support and texting, Just Birth Space, which is listed here, and it's developed by doula Chanel, Portia Albert, and her colleague, M.A. Brill. And so they are not associated with UNC. I just made an abbreviated link here because they have a whole workshop where they walk through Just Birth Space as part of a recent engagement that they did. So that's a YouTube video that outlines their multiple services: Text Connect, We Connect, and Community Connect. Really wonderful reproductive justice space team and services that are available for free. And I wanted you to show that as we in the Patient Safety Learning Lab, this research project, as we continue to build out animations for training around ethical and patient-focused care, we are also soon be sharing tools for use in practice. So for example, there are immense racial ethnic inequities in postpartum pain evaluation and management. And this is something I flagged last time around the importance of addressing people's coping. And so we have tools for more transparency about lots of health topics. What can I expect? How can my healthcare team help? And how might I cope during this time? So those will be available soon, so that we don't have the confusion about people just now finding out about this, and we don't have the inadvertent gatekeeping of things that might help based on people's responses. And so when we think about feasibility, and I'm conscious of the time, I think this might be helpful to go to Menti one more time and have you offer, if you'd like, things that help with these sort of programs and care strategies. I'm going to shift sharing to that. And so, and let me know, yeah, thank you. So having a social worker on staff, time, buy-in from leadership. Dr. Chinnis, you can help me read and respond.
Adequate staffing on both the screening end and also the resource end is definitely a needed resource. You have to have the capacity to be proactive in this space. Community health workers are phenomenal. They are the bridge between the medical community and the actual community itself, creating bonds of connectedness that surpasses what the medical community understands. They serve as gatekeepers of trust in the community. And definitely follow up after information has been sent and provided, as well as just a soft check-in at some point in time, just to make sure that that individual no longer have additional needs. Follow through with clients, that's imperative. We have to start closing the loop of communication, the circle of provision when we're providing services, understanding what resources are needed and how we can continue to meet the needs of our patients. And in the chat, someone wrote, you also need to be aware of the resources that are available for each person, their family, within their community. Correct.
And so in these last few minutes, maybe we can look to the chat or invite anyone who might like to raise their hand with the Zoom feature and come off mute. The other, Menti thing I had, which I'm not sharing for time reasons, is what gets in the way. And I think that's the opposite, not enough time or staffing or perhaps will.
This is Allie from Anthem, Indiana Medicaid. I do have a question, and I brought this to the attention of our medical director. What are your viewpoints as far as our non-English speaking population and having resources available and having an appropriate interpreter available to navigate those resources for those members? Because that is a huge discrepancy that I am coming across as a case manager.
And my immediate response, and then I'll invite Dr. Chinnis and others, is, and we could have been clear, all the resources that we shared are available in English and Spanish, including the websites and 211 and WIC and Salud Madre and the maternal mental health. And I think we shared more, but so I want to be clear about that. Also, meaningful communication, including language concordant care, is a requirement. And yes, I see Spanish is not the only language. And I mean, right now, especially for people who speak other languages, sometimes they have nothing, no after visit summary. And we have video interpreters for in encounters, but sometimes they leave without information to make informed decision.
So in reference to Medicaid, Medicaid actually has a language line. Something that I didn't share during this session that I shared previously is I work in a clinic where we speak multiple languages: English, Spanish, Russian, Cantonese, and a slew of other languages. It's our job to provide linguistic concordant care to our patients in an attempt to ensure that we're providing culturally applicable care. And so definitely use the resources that are afforded to you. If your local language line does not, cannot assist you with the language that you need, use the Medicaid line.
And Dr. Tully, I do use that, but it seems like the interpreters here lately, especially for the Haitian Creole population, I don't know if it's the discrepancy in the dialects, like with our Burmese population. I used to do bedside nursing, and there was times that we could not get an interpreter at all. There is a lot of conflict with how information is being interpreted to the patients that they're discussing with. And we have no idea what they're telling them. They're just coming back saying, this is what she said. I could ask them how many pregnancies of, like, I'm pregnant right now. Okay, so the information is not being relayed appropriately, even through the language lines that we're using, and we have to completely rely upon another person. So I'm just trying to figure out a way where we can kind of bridge that gap so we're getting information appropriately and timely to our patients that are non-English speaking.
Yes, and this isn't directly addressing the scenario that you've just outlined, but one of the things that I've learned is that we don't have access to certified medical interpreters nearly enough, or have access to people being able to be certified. And so we have a lot of hand gestures and things happening and translation through family members, including children. I see another hand raised.
Hi, this is Shy. So I think part of the problem with some of the language barrier is that even when you use the line, and this is just in my experience, when you use the interpretation line or interpreter line, or you have a physical interpreter, the agency still sends the client information in English and they can't read it. So then now you need someone to read your mail to you. Now you need to, a lot of our population, and this is, I had the luxury of having a Hispanic CHW on my team, but a lot of her clients could not even read in Spanish. And some of her clientele spoke Quiche, which is not Spanish, even though they're of Hispanic origin. So there was lots of issues with all of this language barrier stuff.
Thank you so much for this conversation, and I'll turn it to Dr. Verbies to close us out. And this is so wonderful and really directs us to our institutional readiness to serve, and not only people's health literacy. Thank you.
Yes, thank you both, Dr. Chinnis and Dr. Tully, for this wonderful session. I can tell we've had a lot of folks, they've stayed engaged, that we have a lot more to discuss and share as we go forward. And again, thank everyone for all of the work that you do every day to make America a better place for our new family. Have a great afternoon.